Most common complaint that we see in a healthcare provider's office is low back pain. This is a weight-bearing area of the spine. That's your lumbar spine. And in that lumbar spine, we have three structures that can wreak havoc. And it's called a three-joint complex. One joint, two joint, and the joint everybody knows called a disc. A disc is like a cushion. It's got different components to it. And these two joints back here allow you to twist, bend, move around a little. But it all matters. And how many times have we heard somebody say, I just got up, I twisted a little, bloody murder, I got pain. It tends to be in the buttocks area, right there, down the leg a little bit, sometimes lateral thigh. But the point is, it has some variability, but has some hint of suggestion where it might be coming from. Ouch, ouch, you do things like that. I mean, it kind of helps us. But the point of the matter is we have to take history, physical, and medical decision making, put it together with the available tools we got. What's some of those tools? MRI, CT scan, plain films, which aren't so helpful. But the whole point is you put it together. And then you look at the medications people are on, the mechanism of injury, and other comorbid medical problems. So, three joints. Facet, F-A-C-E-T, facet, and disc. Everybody knows a disc. I have bulging discs. Oh, I have a herniated disc. Well, a lot of asymptomatic people are walking around on this earth that have bulging disc and asymptomatic herniated disc. It doesn't always matter. What matters is what it does to you. The inflammatory component of, say, for example, the facet. The facet is a true synovium. It's a true synovium like your knee, like other joints and your fingers, and it can be inflamed. It can get inflammatory, it can hurt, it has to do with chemicals, it has to do with a lot of things. I guess that's why we inject steroids, because steroids settle some of those inflammatory mediators down, like cytokines, etc. But the point of the matter is, what are we going to do? Improve function, quality of life. I have low back pain. Rule 2, remember, Rule 2, low back pain is not a diagnosis. Rule 2, you must have a diagnosis. Low back pain is a symptom. This joint can hurt, that joint can hurt, that disc can hurt. Well, everybody wants to treat the disc. Well, I'll just get surgery and fix it. I don't know. Well, let's look at the big picture. Let's say you have minimal or not necessarily dramatic findings on the MRI where the disc is pushing on a nerve or rubbing on a nerve, or these joints don't look really arthritic, or the spine isn't twisted or bent or something like that, and you want to do something, right? So you look at what you can do to get the most for the least. So okay, let's look at this. I don't know why nerves are yellow, but here it is. This is a segmental nerve. It comes out of this hole called a foramen. This stuff's not that important, except when you hear things thrown around like terms such as stenosis. Well, foraminal stenosis, I guess there's not as much room in there for the nerve. It could be coming from that facet, or it could be coming from that disc pushing back, could be coming from a lot of things. But the point is, bones don't hurt, muscles don't hurt, nerves hurt, right? So how can we help? And what can we do? Well, these joints tend to have certain characteristics. Buttocks pain, thigh pain, usually above the knee, usually. Where the hip bone comes together with the spine, sacroiliac joint, it's a true synovium on the bottom third too. That can kind of confuse things. So what we do, assuming that the bedside tests, the tests we do on physical exam aren't all that great, is sometimes we put medicine in there, diagnostic and therapeutic. In other words, we can make a diagnosis as well as treat it. And sometimes that treatment involves local anesthetic steroid, a number of different things we can employ, but the anatomy matters. So that joint, the facet, has a small branch of this nerve come off here called a medial branch. You may hear the term radiofrequency ablation. You may hear the term RFA. You may hear the term radiofrequency as it stands alone. That little nerve is a nuisance nerve. It's called a sensory nerve. It doesn't really add much. There's two types of nerves: sensory, ouch; motor, I move. The segmental nerve is I move. That little branch of the segmental nerve, called the medial branch, innervates the joint and the back third of the disc. So it covers pretty broad brushstroke. We can get to that little nerve. First of all, we can put local anesthetic on there and you say, I feel better. I can move around a little better, bend, twist, sit longer, take less medicine. And it's relevant. And it always wears off. People never remember that. They say, oh, it didn't work. But no, I told you it's going to wear off. I told you it was going to wear off. But the point is, while it was working, the local anesthetic, maybe get a little delayed steroid effect. While it was working, did you feel better? Could you do more things, sit longer, go to the grocery store, play with grandchildren, all that sort of thing? Keeping track of that, a mental note, mindfulness of what's going on. Yeah, I was doing fine until I chopped a cord of wood. Well, that didn't help. So what can we do? So back here, we can address the joint with a positive block. We call it a positive predictive experience. We can put a small little needle with a tip that gets a little hot from that machine, and through a lot of technical gyrations from the information we get, we can cauterize that nerve. Cauterize is not exactly the right term, but we can stun that nerve and we can take care of some of your low back pain. Axial pain. This is called axial pain. It doesn't go down your leg. Down your leg goes to radicular pain. That radicular pain tends to have certain characteristics. If it's on the outside of the foot, the bottom of the foot, towards your big toe, it's just different nerves. That's coming. We'll get to that. I don't want to go too far into the weeds. But when you start getting nerves rubbed at different level, that segmental nerve, characteristically, you can kind of figure out what level is the problem. Because the disc is pushing at L4, 5, 4, 3. There, it's pushing, and it goes in a characteristic pattern down your leg, and you may check reflexes, you may do some other provocative movements and that sort of thing. You're starting to kind of get it. The MRI kind of fits the history, physical, and medical decision making. So we can do an epidural. You hear interlaminar, not translaminar. Translaminar means we went through that bone called the lamina. No, interlaminar means we go in here. Epidurals are a great option. Interlaminar epidurals aren't as specific as putting it in there around that nerve. It's called transforaminal. Okay, so we're getting a little into the weeds, but you can see 3 joint complexes matter. It matters to our medical decision making, where we're headed, and the pathology that we're looking at. MRI, CT, history, physical, medical decision making. You're getting it. So we're kind of getting it. We're starting to figure out low back pain. And we have options like RFA, we have steroid injections, we have diagnostic injections with local anesthetic. We have different ways of approaching this. Of course, ultimately surgery. Of course, we want to exhaust conservative management, physical therapy, chiropractic. If you want to do acupuncture, fine. I'm trained in acupuncture. I mean, it's good. I think it works for reasons that people don't think it works for. It's been around 5,000 years. Why not keep using it? I mean, you know, the risk-reward benefit's probably in people's favor. But the point is, explore your options, understand how to talk to the person in front of you. And like 4 or 5 things you can say. Don't come in with the book. Dr. Google doesn't help anybody. But 4 or 5 things that make sense. But I notice my leg gives away. My foot, I don't have as much strength. Foot drop. It means something. I can't sleep. I twisted, I bent, and I have this bloody murder back pain. That stuff means something. So we're starting to figure it out. Okay, that help? All right, we're starting. We're going to do more. We'll get to the neck.